Hi, I'm Alicia Gonzalez, emergency physician and the clinical training director for the California Bridge program. And I'm here today to give you just the briefest overview of opioid use disorder and, more importantly, medication for addiction treatment. Unfortunately, we are all way too familiar with this graph that shows the tremendous increase in the number of opioid associated deaths since 1999. In fact, in 2021, in the US, we had a record breaking over 100,000 deaths from opioids. That was more than the car accidents and gun victims that year combined. These are not the kind of records that we want to be setting, and we've got to do something about it. How did we even get here? That's a very long story. But the gist of it is, back in the 1980s and 90s, we were really focused, a big push in medicine on getting rid of all pain. And at the same time, Big Pharma was coming out with these newfangled medicines like oxycodone, which they said were extremely safe and not dangerous and should be used widely for all of our patients. So we sort of set this expectation that anybody with pain would get opioids. Simultaneously, there's a significant increase in the amount of heroin coming across the border from Mexico. And of course, our patients then and now have had limited access to care, behavioral health or otherwise, and in more recent years have had more struggles in the economic and emotional portions of their life than ever before. You put that all together, you've got yourself a perfect recipe for the US opioid epidemic. Thankfully, the neurocognitive research out there has shown us unequivocally that addiction is a chronic medical disease. It is not a moral failing. It's not bad people. They're just regular people who, yeah, maybe made unfortunate choices and started using drugs and developed addiction. But just like any other chronic medical illness, diabetes, obesity, high blood pressure, cholesterol, there are a lot of diseases that are the results of our choices. And that does not stop us from helping provide evidence based treatment, medication to help with these chronic diseases. Why medication for opioids? Because if you use opioids regularly over time, ultimately your body builds tolerance. It needs more of it to feel the same way, but in the end, develops dependence, meaning it requires some opioid to be present in your system to even feel normal. Without it, you enter withdrawal. And opioid withdrawal is miserable, super painful, brain on fire, vomiting, diarrhea, like horrific experience. And so you have to have a little bit of opioid for your brain chemistry to normalize and for you to just feel normal. But not only does medication make you feel better, it literally saves lives. If you look at the average rate of death, say your risk is one, somebody who's using illicit opioids like fentanyl, their risk of death is 6 times higher. But if you start that same patient on buprenorphine or methadone as medication for addiction treatment, their risk of death approaches that of the regular population. This is a massive reduction in mortality, and it makes MAT for opioid use disorder one of the most effective and safe things that we can do for our patients. For us in the emergency department and in the EMS system, we know patients who have just overdosed and who required naloxone to come back to life are actually at their most vulnerable point. Their risk of death is highest in the next 24 to 48 hours, which gives us a very special moment and opportunity to help intervene and save that life when they are most vulnerable and at risk. You'll notice I said just start medication, start treatment, not fill out a bunch of paperwork, go to a specialty clinic, do a urine tox screen, et cetera, et cetera, et cetera. No, there are currently a lot of barriers built into the system, but our job is to lower the barrier to entry, to get rid of all these nonsense requirements and just start patients on medicine. Medicine that helps with cravings and withdrawal and prevents overdose. And there are multiple options, but we like to use buprenorphine for a couple of practical reasons. In our setting, buprenorphine is an oral medication that gets absorbed in the mouth. Don't swallow it because it gets absorbed differently. So orally absorbed. And once the buprenorphine is in your system, it is a partial mu agonist. That means it partway turns on the opioid receptor. This does not cause euphoria and high the same way that a full agonist like methadone or heroin or fentanyl will, but it does take away cravings and it takes away withdrawal symptoms. It helps normalize the brain chemistry so someone can just live their life. Things we love about buprenorphine include the fact that it has a ceiling for respiratory depression. There's no ceiling on the dose. You can go up, 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 up on buprenorphine, but it won't cause overdose all by itself the same way methadone or other medications can. So that makes it really safe. It's also got a really long half-life. So it can be taken as once or twice a day dosing. Very practical. Patients can go home with a prescription. They don't have to go every day to a clinic. And so for all these reasons and more, we like buprenorphine as a practical solution for us. It's safe in pregnancy and breastfeeding. You don't have to be in the hospital to start it. Patients can self-start on buprenorphine with good instructions, or a medic can help them start it too. You don't have to have a doctor there. It's safe for minors. Just make sure you know the consent rules for treatment in your local community. And if somebody's on buprenorphine, they need to stay on their buprenorphine, even if they're going to enter some kind of pain. So if they have like a broken leg, yes, you can add acetaminophen, NSAIDs, fentanyl, et cetera, but you got to keep the bup on board. Patients are often on buprenorphine for a really long time. Remember, we're treating a chronic disease here. It's not a treat and treat problem. So patients can be on buprenorphine their whole life, the same way somebody might be on insulin their whole life. And we should not be pushing people to stop taking their medication. As far as diversion, we're not as worried about that. Most patients who are looking for buprenorphine on the street are actually trying to be in treatment. If they wanted to get high, they would just buy fentanyl, which is cheaper and easier to find. But if we can lower access, make it easier to access buprenorphine from us, from the medical channels, then diversion won't be as much of an issue anyway. Not all patients are going to want to start treatment, and that's okay. We can still talk to them about harm reduction, not using drugs alone, and give them naloxone. We want to put it in the hands of every single person out there. It's like the AED or CPR of our generation. The more naloxones in the community, the more equipped somebody can be to help in the event that somebody near them does overdose. We are definitely sick and tired of our friends and family and community members and patients dying from opioids. So our goal together is to make sure that we treat addiction like a chronic, treatable medical disease, that we put evidence-based buprenorphine, MAT, in the hands of our patients, and that we work together to decrease stigma and increase access to care. Welcome to the new standard of care, which is MAT for opioid use disorder. And I want to personally thank you for everything I know you will do to help us save lives.
Thank you, Dr. Gonzalez. That was super helpful and a great overview of the greatest public health crisis that our country is facing right now. What I'd like to do now is talk to you a little bit about EMS-initiated buprenorphine and how you, as a base hospital provider, can help the medics when they have questions about this protocol. So once again, my name is Hern. I'm the EMS Bridge Medical Director. Now, a little bit of background about EMS buprenorphine. So EMS buprenorphine was a protocol that was started, I guess we started it about 4 or 5 years ago. We based it on the work out of Jerry Carroll in New Jersey. They can give buprenorphine post-naloxone-initiated withdrawal. So patient overdoses, they get naloxone, then they have withdrawal symptoms, they can give buprenorphine then. We expanded that inclusion criteria to be any patients who have received or rather any patients who have opioid withdrawal symptoms, either receiving naloxone or pure abstinence withdrawal. And we've discussed this in the literature and our experience in Contra Costa County, and we have a pretty decent follow-up rate for our patients. About a quarter of our patients are in treatment at long-term treatment at 30 days post-EMS buprenorphine, which means for those patients, they have about a 2/3 reduction in mortality, which is really significant. It's really important to think about that. We also talked about the concept of an overdose receiving center or a bridge hospital. In California, we have, I think, over 250 bridge hospitals at this point. Some have been functioning very, very well for many years, and some are just starting out, so may not have all of the pieces in place yet. But that's the concept. We went from an overdose receiving center sort of name to more of a bridge hospital site. We also know that patients who are not transported post naloxone have a high incidence of other overdoses. So what we did was the EMS Bridge protocol for EMS-initiated buprenorphine or buprenorphine field starts mimics a lot of the things that you might have already seen in the ED Quick Start Guide from California Bridge. Our guidelines are remarkably similar. The paramedics are going to call you as a base hospital provider if they have additional questions or other concerns. So that's why I wanted to familiarize yourselves with the protocol itself. It can also be found at emsbridge.org. But basically, the medic looks over the opioid signs and symptoms. Obviously, we're looking for objective signs. They have to have 2 or greater of the objective signs. Remember, yawning and rhinorrheal lacrimation are incredibly specific. And then other subjective symptoms, although obviously those are subjective. They also are going to look at exclusion criteria. And this is really important for you as a base provider if they call in. I've answered a number of these calls over the years when we required a base call. And what's really important in all of these exclusion criteria, I think the first thing is no methadone for 10 days. Remember, if they get buprenorphine and they have methadone in their system, their withdrawal symptoms can be worse. That's precipitated withdrawal. That's bad. It's bad for us as providers because they're sort of difficult to take care of. Luckily, the rate is incredibly low. We've only seen about 1% precipitated withdrawal in these EMS patients. The other thing is we have to make sure that the patient has an opioid use disorder. It wasn't just that they were at a party and did a white substance and then woke up with 4 paramedics and a bunch of Narcan boxes around them, and they thought they were doing cocaine or something else. They have to have an opioid use disorder, so chronic opioid use. We've lowered the age to 16. California law now allows 16 and over. And then other exclusions, like they can't have like bad CHF or respiratory distress or some other sort of significant severe medical illness. And they can't be altered so much that they can't give consent. We leave this up to paramedic judgment. They make this decision all the time for lots of other diseases. And so we wanted to specifically sort of say they have to be able to sort of be awake and consent to that. They have them do a COWS score. Initially, the EMS protocol had a COWS score of 7 or greater. That was the EMS-based protocols. We've now aligned that with California Bridge ED Quick Start Guide, which has a score of 8. It's a pretty subjective score anyway, and most of our patients who get buprenorphine have a COWS score of 16-ish. So that wasn't a significant change for us. But what we did want to do is align it with the ED protocol. So the Bridge covers both EMS and ED starts of buprenorphine. Obviously, you're all familiar with what a COWS score is to assess severity of withdrawal. If it's 8 or greater, then they can give the patient's buprenorphine without calling base. Now, each EMS agency is a little bit different. Some still have it in their protocols. Some are about to change. But as a base physician, I think, or a base provider, I think it's really important for you to know that it's still possible that these paramedic clinicians might call you to run a case by you. It might be the first time they've given it. It might be a complicated case. Maybe they had a question about the methadone. But I want you to be aware of this protocol so that as a base hospital provider, you can help the paramedics who are in the field dealing with these challenging situations. But also remember, these are life-threatening situations. If a patient overdoses in the field, they have about a 10% mortality risk in the next year. That's basically equivalent to having a STEMI. So it's incredibly serious, but I want you as base providers to be able to support the paramedics in your system to answer questions and be familiar with this protocol. So we have in the protocol, consider base contact for complex cases or additional support. And that's why we wanted to do this video specifically for EMS base hospital providers. So then we allow the paramedics to give 16 milligrams sublingual, those little film strips of buprenorphine. And then if the symptoms persist, they can give another 8 milligrams or another strip. So for a total of 3 strips. Then we ask for them to verify the contact information, provide 2 phone numbers, and provide leave behind naloxone. Document a repeat COWS score. On average, our COWS scores go down by about 7 points post buprenorphine. We also recommend transport to a bridge hospital. Obviously, every EMS system is going to be different, and not every EMS system has bridge hospitals in each of their systems. If the patient declines transport, please, the paramedics will let them know the navigator still may reach out to provide them with support, prescription, or follow-up appointments. If you have further questions, more EMS protocols can be found at Bridge to Treatment or EMS Bridge. You can QR code this, and if you have any questions, please contact us, emsbridge.org. And again, thank you for your time, and thank you for your help for the paramedics who are using this novel intervention and this novel medicine, although medicine is not that novel, and it's clearly the standard of care for this greatest public health emergency. Again, thank you for your time, and I really appreciate it. Thanks for taking care of our communities. Bye now.